Dr. Parijat Chandra now, and he's doing an ROP surgery at present at the RP center mostly. He's the one who's doing it, and he's going to talk about indications, complications, role of anti-VEGF when, and bilateral surgery also. And in 10 minutes, he'll tell us all this.
Right. So, good morning. So, there are a lot of challenges involved in ROP surgery. As we are well aware, you need a strong and ICU backup. You need an experienced pediatric anesthesia team. Otherwise, you can spend hours just finding a Venflon. And so when should we operate these cases? Just to show you, this is a case which came to us. You see, it's detaching in both the eyes. It's in stage 4A, and you see traction is there. It's already lasered. It's bleeding in one of the eyes. So when should you operate this case? So this case right now is ready for surgery because it's going to lift up very soon, and despite laser, it's not stopping. Unfortunately, the child was sick and could not be operated, and the next 2 weeks, this is what it came. It became from stage 4A to stage 4B. And now the prognosis which was there earlier is now much poorer than what it was. What you could have got away with a very clean surgery is now not possible, and the macular involvement is there. So we need to understand that if you keep on delaying surgery, it's going to pick up more height, it's going to become more peripheral, the instrument access is going to become difficult, it's going to become more vascular, there's a higher chance you'll have intra-op bleeds, post-op bleeds, the lens might get involved, and you might have, have to remove the lens, and macula might get involved, and then, the outcomes will not be as good as you thought it would be. So how are the results in stage 4 ROP? So let's see this case. This case has an extensive stage 4A happening in the nasal side, and so if you operate these eyes, it comes out very nicely in the end, and so it really works very well. Another case here, you see it's again stage 4A. It's got already lasered, and vitreous hemorrhage is happening in this eye. So again, if you operate this case, again the outcomes turn out to be very nice. What you see the laser marks behind is posterior barrage laser. So we combine it with surgery intraoperatively, and this helps to get these good outcomes. So what I'm trying to basically say is, you go in early and the outcomes will be much better. If you go in late, the outcomes will be poor. So you refer in time and treat in time, and the outcomes will be better. So this is show you one of the cases. Typically, what a case would look like in stage 4A. There's a band which you need to cut from the disc towards the TRD, and once you cut that band, you see the extensive traction is there. You can see it's been lasered. Fresh laser marks are there, and you see now the traction has been relieved over the TRD. It bleeds sometimes because this is all vascular tissue and vitreous is attached there. So, but you need to effectively release this traction, otherwise the ridge is not going to fall back and the tissue is not going to go away. So now diathermy is being done there, so that effectively no intra-op or post-op bleed happens later. And once you release the traction all the way around, then PVD can be done, and so that later a drag or nothing doesn't happen. Another case here, this is of a more zone 1 AP ROP, where you see a more posterior TRD is there. So the idea again here is to remove the traction which is there over the TRD, and once all that traction is removed, you see how yellow the vitreous is right now. It's full of these factors. See, fresh laser marks have been given just before starting surgery within LIO, and now you see PVD is being done, and the traction over the entire TRD is relieved. So you see a large amount of laser has been done in this case, and you see in the end this is how it looks like at 4 weeks. So all this can go away. So this case is much beyond what it should have come. It should have come earlier to us, but even with that, it comes out well. There's another case, now you see how heavy laser has been done, but membrane still continues to develop despite such a heavy laser, and this TRD develops, is going to stage 4B sequelae. Macula has started to form a falciform fold. When you have a primarily posterior surgery, then 27G vitrectomy can work very well in these cases. 27G is difficult to do in peripheral situations because the control is a little less. But in this situation, when you have a simple bands like this, you see the temporal TRD is there, and the band is, the vitreous sheet is being cut between the two. And once you can relieve all that traction which is there, then this further fold progression will stop. However, when the RD becomes peripheral and starts to come behind the lens, then the lens sparing vitrectomy is not possible, and then it cannot be approached through a lens sparing approach, because the instruments will get stuck behind the TRD, and the infusion will not happen, and other problems will happen. Then lens sparing becomes difficult in these cases. So it's always best to go in early when the instrument access is there, and the lens can be saved. Many times we combine PPV with anti-VEGF. Let's see this case. You see what is happening here right now is the child has already been lasered. It's a zone 1 case, and there's extensive TRD which is developing, and also has a lot of neovascularization. So in these particular scenarios where there's extensive neovascular proliferation, in those scenarios, surgery alone will not help, because you can relieve the traction, but the neovascularization will not go away, and the process of traction and progression will continue. So in these cases, if you combine an anti-VEGF intraoperatively along with a vitrectomy, you can get a very good outcome. So this kind of outcome cannot be obtained by surgery alone, and combining anti-VEGF with the surgical procedure really helps. So how do we do it? Under air. Once you are there, then inject half dose Lucentis we inject intraoperatively using a soft tip needle. So that's the entire procedure that there is, and it works very well in these cases. But once you inject anti-VEGF, again you need to realize that the life of the anti-VEGF is around 6 to 8 weeks, and there's a tendency for the disease to come back. So what you see on the right side photographs is what happens at 8 weeks. You see again flat fine neovascularization has started to come back in this area, and if you see it's the same area where it was there earlier. And if you do an angiography, you can see that it's extensively coming back. So this child had to be injected again. So you need to keep a watchful eye. Even if a clean outcome, it's not necessarily that it's gone away. And then there's a scenario where there's rapidly progressive bilateral disease. So we like to do the surgery in the same sitting, because it really helps to fix both the eyes in the same sitting. If sometimes you operate one eye, child becomes sick, and the other eye might progress to an advanced stage. So it's better to do it in the same sitting. And obviously we understand that the GA induction and extubation are the highest risk phases in sick babies. So this allows you to do only one session of intubation extubation, and it works very well in these cases. But obviously you need to have a high safety margin, otherwise you can end up with big complications like endophthalmitis. So the second eye is treated as independent surgery. You change the drape, the infusion fluids, the instruments. The entire team rescrubs again, and 2 sets of post-operative drops are used. So for all this, parent counseling is very important, and informed consent is to be taken, because you should clearly explain to the parent why you are doing both the eyes in the single sitting. So and all precautions we are going to take, but it's going to help the child to operate in the same sitting. Many times earlier in years we used to operate one eye and do the other eye later, and the child used to get sick. We used to operate the bad eye first, and the child used to get sick, and then the better eye used to become bad. So this really helps in fixing both the eyes together. Let's talk about some common complications. So newcomers who are starting in this might encounter some complications. Like you see what happens here is just the light goes and hits the retina, which you see a small break has formed there. So it can form, but there's nothing to worry. Just go ahead and laser it. Don't try to induce PVD there, and don't try to do too much manipulations there, and the surgery proceeds as usually as you want it to proceed. Another complication which happens because you see hardly there is any space for the instruments to move. So sometimes the cannula you see is very closely placed, and it can sometimes bend over when you're trying to insert the lens or something, and it can have a lens touch which is there. But this is more like indentation of the lens which has happened, so nothing needs to be done. You continue your surgery as usual. Obviously the child can have a peripheral cataract in these cases, but nothing else needs to be done. You don't need to remove the lens, and you can continue the surgery as usual. This is a more serious complication where just in the middle of the surgery, suddenly you see what happens is that again, because the infusion cannula gets misdirected, it can go in the suprachoroidal space, and all the fluid has gone there, and it's a very shocking situation to happen. But there is nothing to get worried, because it's again you know what has happened. You know why the cannula has gone there, because there's a lack of space, and if you move too much, the cannula can misdirect. So you have to be very careful. The cannula is in the right place. The cannula is not coming out during the middle of the procedure, and then you just let it drain out, remove the infusion, and just press along, and it comes out fine at 4 weeks. You see everything has just settled back on its own. So you don't need to do too much manipulation or retinectomies and drainage. Nothing needs to be done. It's just fluid which has gone inside, and you just need to recognize what has happened and fix it accordingly. Postoperative bleed is a huge problem, and never bleed bleeders. Do the good diathermy and lower the pressure, see where the bleeders are, and fix the bleeders, and they should be fixed. Stage 5 ROP is a different problem. All these are potential medical legal cases, because they are blind forever. They have never been screened mostly, but we give trifocal navigal vision in these cases. This is just to show you how I like to do it. So these are 23 gauge MVRs which are going in, and this is like this allows easy access to 25G instruments through a clear corneal approach, because all this tissue is stuck behind, so going through the sclera is a difficult option here. So once the 3 ports are made, you can go ahead and relieve all these synechiae which are there, and after that you can do the lensectomy, and now you have this dense retrolental membrane which is there. The MVR can be used to make an opening in the retrolental membrane, so that all this tissue can be accessed which is behind. And once you create an opening, so you can make a linear opening, you can make a cruciate opening, depending how much excess space is there behind the retrolental membrane. And once you can remove all that, then you can enlarge the opening with the cutter. And so I'm trying to just tell you that stage 5 should be operated. It's a difficult surgery. Many of these babies are blind forever, but you can give a trial for navigal vision. And as you see, you continue to dissect into the posterior areas. You can continue to open the funnel, and you see this is the last bit of tissue which is going out. You can see that that is removed, and you can see that the disc is there, and you can see the macula is there. The macula is attached. But you see it had so many barriers in between, like the lens, the posterior synechiae, the retrodental membrane. So all this can be just hydrated, and then air can be injected, and this is how it will come out in the end. It's a sutureless technique, and you say air tamponates from inside, so the air also doesn't leak out, and the wound is self-sealed from inside. So it's a clear approach. No pupiloplasty is needed, nothing is needed. So this is to show you results of another cases. So what I'm trying to say is that many of these cases do have an attached macula, many don't have an attached macula. I'm not trying to say that the prognosis is good, I'm trying to say the prognosis is very poor. But however, what I'm trying to say is that surgery should be attempted, because these babies are blind anyway. And if you give a trial for surgery and they get some kind of navigable vision, maybe hand movement, maybe close finger counting close to face, their life changes, they can recognize their parents are standing, they can walk from here to the toilet. Things like that happen, and that is also helpful to a baby who's totally blind. So we should attempt surgery in these cases. These are the best of the best scenarios, but mostly the prognosis is poor, but it's helpful to these babies. Thank you so much.
Thank you, Dr. Parijat. That was an excellent talk.